So I was explaining the issue of multiple partner. Could I be able to see the slide, please?
Can you see it now? Let's see if I have video on.
If it's a problem, we can try to move without that.
Nope.
Skype, you might be able to say share screen.
I know, but we're losing the connection. That's why I just need to get the... Just one moment.
Okay. Yeah. Excellent. So I was explaining the context, South African context about multiple partner, which may be in some way different in the United States, but I'm sure this may be, there's been some issue about value norms, issue about due to poverty, many young girls just prefer exchange of sex for resources, and a phenomenon here called sugar daddy and mommy. So that is prefer a young partner while they have, so those older people prefer a young partner, which put those young partner at high risk of HIV, because those older people are more likely to be infected with HIV. And then there is married men who are unhappy at home. It's an explanation here that they try to strengthen their home in some way. Some males may prefer to have sex with other males because of expectation from society to hide their sexual preference. So in the United States, some people call it the down low phenomena. The power dynamics, I think it's very critical in South Africa because of gender imbalance between men and women, which also creates some vulnerability. Next slide. So now, moving forward, I think most at-risk population with multiple sexual partner, when one analyzes further this issue about partnership, this slide presents a finding which show that the high-risk drinker and those who use recreational drug have high rate of multiple sexual partners. So this is not a surprise, which basically is not specific for South Africa, as it can be shown, it's been shown also elsewhere. Next slide. How about condom use? So this data try to capture condom use behavior from 2002 to 2008. Not surprisingly, condom use is not really great in general. Obviously, there seems to be a trend upward, so some increase over time, probably due to aggressive prevention campaign in communities, so that at least it's a good news. But one would like really to see almost 100% condom use, so better figure than what we are seeing here. But at least we have here a positive trend. Next slide. When it's about condom use by most at risk, the figure are somewhat lower, but also here over time, there seems to be a positive trend looking at subgroup like African female, African male, or older male, or at high risk drinker or drug user. So next slide, try to capture the testing seeking behavior, and also it showed that over time more people in South Africa go forward to get tested for HIV, but we still we still need to scale up this program, because as you can see, it's only about 50% who people are eligible who are coming forward for HIV testing. But again, there is a time there seems to be an increase about people seeking HIV testing. In the United States, you have now FDA did approve home testing for HIV. This is being now debated in South Africa. We hope with home testing, it will give more incentive for people to get to know their HIV status than going to a health facility. Next slide. So now I think I gave you some pretty comprehensive epidemiology of HIV in South Africa. Now what? What are the interventions that has been around to try to turn around this epidemic? The previous HIV prevention strategy has been abstinence, behavior change, condom use, counseling and testing, and somewhat recently, circumcision. I have to admit that none of these HIV prevention strategy address the vulnerability in young women. So all these prevention strategy, at least in the South African context, does not make a difference in trying to prevent HIV in vulnerable young female. As I show you, the epidemiology is really affecting badly, mostly young female. So the next slide going to show you maybe the first game changer, and this is the highly publicized study called CAPRISA 004. This was a study conducted in South Africa in the province of KwaZulu-Natal in the northeast of the country by Professor Abdul Karim. These data were published in prestigious journal Science. This study tried to look at the HIV incidence of a drug called tenofovir that was it was administered as a gel. So young female have to, before having sex, have to apply this gel, and the idea here was that this gel could prevent HIV acquisition, and in fact it did. As shown here, in overall, there was a protective effect of this gel with patients in the intervention group have lower HIV incidence compared to the control group. So basically, the blue bar are the placebo, and the purple bar are the group who benefited of the intervention. And as you can see, at different follow-up time, there is less infection, so the incidence is lower in the intervention group compared to the placebo group in overall. They tried to look at the data stratified by adherence or compliance of applying the gel. It was not a surprise that women who applied the gel consistently were better protected than the ones that were less adherent to the drug. So I think I wanted to show you this data because, first of all, it was a proof of concept. For the first time, we had an intervention which targeted the more vulnerable group of women in South Africa, and secondly, which shows some good results. It was not 100% efficacy, but it was at least about 30% efficacy. The next slide, it's another study. So this was not, it was a multicentric study conducted in many countries, including in Africa. It's called the HPTN 052. And next slide. This study basically, which was announced in May 2011, showed that And an HIV-infected person who really is compliant to his treatment, so this is no longer only women. This was male and female taking not a gel but a tablet orally, that taking treatment early on not only keep you healthy but also protect your partner, your sexual partner, for acquiring HIV. So for the first time, we have strong data which show that HIV not only keep you in good health, but also protect your community, because the virus is suppressed. So the likelihood of transmitting the virus to your sexual partner is almost null. So, and the efficacy was calculated at 96%. So next slide. Basically, on the next slide, I would like to introduce you to a concept which you probably heard about recently in the press. Is called the test and treat strategy. So far, for treatment of HIV, an individual they used to use what they call a CD4 threshold. So until you reach a certain level of immune deficiency, they will just follow you up. And when you go below, let's say 300 or 350, then they start to treat you. But this concept try to say you should not do that. It makes more sense that as soon as someone is tested positive, and right away the person have to take the treatment. And this type of strategy was based, next slide, on mathematical modeling. It's an animated slide, so keep going. I will let you know when to stop. You have, okay, stop. Stop. You have basically three figures there. The one in the middle, it's the figure which basically look at the prevalence. The one at the top look at the incidence. The one at the bottom look at mortality. And I think it's the color. It's a community without treatment. What can happen over time? So basic incidence and prevalence will just keep going. This is mathematical modeling. The current strategy, which I told you, is that, for example, in South Africa, they start to put someone on treatment only when the CD4 is below 350. But that strategy in blue here show that under that strategy, the figure on prevalence and incidence show that you're not going to get rid of the epidemic with such a strategy. Obviously, as it shows, mortality decrease because you're treating people, they're no longer dying, but you don't get rid of all the mortality. There's still people dying, but not as much as before. But what this mathematical model proposed was that you should not wait any threshold of CD4 or immunodeficiency. You should just go ahead once someone is tested positive and just treat everyone. And as is shown in green, with such a strategy, you will eliminate HIV in the community. So this is a strategy that is being debated really over these days. And the next slide, for those who heard about the R0, which is the basic reproductive rate. So R0, you need to have a R0 of about less than 1 to get rid of an epidemic in a community. The definition of R0 is the average number of persons infected by a single disease source. In other words, this is the number of expected secondary infection resulting from a single infection case. Another way also of explaining R0 is the number of people who are expected to be infected by one person who has the disease in question. So that have been said, the best strategy here, if you test everyone at least every year, and you try to treat them when they're still healthy, not be when they are CD4, which is on x-axis here. When their CD4 is still above 1,000, you are likely to be in the green area. That green area going to allow a R0 of less than 1, so which going to make possible the decrease of incidence of HIV and over time elimination in the community of HIV. So that's what the test strategy is about, and which currently, whether you are in South Africa or in Europe or in the United States, everyone is debating that that's the way to go now to get rid of the HIV epidemic. Obviously, it's going to require a lot of political will, a lot of resources, because that means you have to treat everyone as soon as they test positive. But the problem is, as I just informed you, not everyone go forward to get tested. So there's still people in a community, they don't know their HIV status, they are HIV infected, they're still transmitting the disease. And in Africa, because of the lack of resources, sometimes you have people who are HIV who cannot access drugs because drugs are not in some setting subsidized by the government, or they are not free of charge, and some folks cannot afford to pay the drug for themselves. In any case, the concept of test to treat is a very elegant one, and which basically is the ideal strategy to get rid of the epidemic. Next slide show you South African data, which just recently been published in Science, which somewhat validate the concept of test and treat, because this is a community in KwaZulu-Natal, a province in South Africa, which is highly affected and where the HIV prevalence is close to 30%. It shows basically that in such community, if you increase the coverage of HIV treatment, over time, you're going to get a return in decreased HIV incidence. So the next slide show you the decrease of incidence over time as you increase your treatment coverage. And for a treatment coverage in community of more than 40%, you see here the decrease, a very nice dose response by treatment coverage, how the adjusted HIV acquisition decrease over time. So this is really very powerful data which show what you can achieve if really you get treating people early, and you treat almost everyone who need to be treated and not wait until they continue to transmit in the community. This is assuming also that our patients are compliant, adherent to treatment, because even if you get tested and start on treatment, but you're not taking your treatment, this is not gonna happen. Next slide just give you a summary now of all the possible intervention that the efficacy over time. Obviously, at the bottom, you see that the HPTN 052 study, which show about 96% efficacy, this is the highest efficacy we ever document through an intervention to get rid of HIV. But look at medical male circumcision, which is about 60, so actually 57% efficacy. So this was proven through randomized controlled trial, which were sponsored by NIH in South Africa, Uganda, and Kenya. So far, HIV treatment, so antiretroviral therapy, seems to be the one that showed the best protective efficacy with 96%. Male circumcision about 60%. You can notice that the current vaccine, the vaccine we've been tested so far, it's only 31%. So we're still far to get the vaccine to get rid of HIV, as the efficacy is still really lagging behind. For a vaccine to be really great, you need at least 80 and more of efficacy. Next slide. So I think I will just try to conclude, and I'm really welcome to discuss with you, to have questions, and I'll be happy to answer. But I would like just to say, in the South African context, I hope I've been able to convince you that we need more protection for women, and especially the ones that are likely to be infected, the younger, likely to fall pregnant, they need to be protected, and I think if we can improve the efficacy of the tenofovir gel, which is being now tested in phase 3, that will be great, because women no longer need to negotiate with partner use of condom. They can just apply the gel whenever they feel that they're going to have sex, and it will protect them. And I think the issue of multiple partner is something that through counseling need to be addressed. The issue of fight against poverty, which put huge proportion of people under risk of HIV, also need to be addressed. The next slide show that we need to step up, to scale up HIV testing. The more we get tested, the more people know their HIV status, the more you can channel them to access treatment early, so they can no longer be transmitting to their community. And as the mathematical modeling show you, and data, community data are showing, the more people are being treated and taking their treatment, it's good for them, but it's also good for their community, because they're no longer transmitting, so the community incidence is likely also to decrease. In summary, with this next slide, I thought it was good to show you what today we can do. And today we can continue to advocate for condom use, both for male, and there is some female condom available. For men, we need to stress, being shown that male circumcision protect them for acquiring HIV and in secondary to transmit it. Treatment as soon as possible, test and treat strategy is something to implement whenever it's possible and affordable. That's what is called ARV treatment as prevention, not only for the individual benefit, but for the community social benefit. There is now, more work that needs to be done in terms of microbicide to try to have better gel with better protection before we can roll them out. But that's the future, especially for women, because they target specifically women, those microbicides. And you see at the bottom, we're not yet there about the vaccine, but people are working very hard, because the magic bullet at the end of the road hopefully will be a vaccine that will be as effective as we used to have for childhood diseases. So let me, this is my last slide, just to say, we're now in the era where we need to combine, intervention, so combining counseling, circumcision. Next slide. So combining all these interventions are likely together to make a difference at community level. Next slide. Next. Thank you very much. This is where I live, and I'll welcome you to visit me, and I'm happy to take a few questions. Thank you.
Before we go to questions, as the prompt is the sheets are being handed out, the question is, detail one of the promising strategies for the reversal of the HIV epidemic. Sure. Detail one of the promising strategies for the reversal of the HIV epidemic. And what I would recommend in this case for Q&A is if you have a question, if you could come up closer to the computer so that Dr. Nachega can hear the question.
Veronica?
Yes.
Could you allow me? I would like to make an announcement.
Sure.
I'll be teaching a course in the summer term at the School of Public Health. This is the first time that course is being given. The title of the course is Global Tuberculosis and HIV Control. So those who are interested are happy. I'll be happy to give them more information. Just send me an email, and I think those who are interested on global issue like HIV and tuberculosis, that course will be very beneficial. And so it's going to be in summer term in July, and it's one credit course. Thank you.
Dr. Nachega, with your permission, then I will post your email onto the Blackboard site so the students can have it.
Yeah.
Yeah, and I will send you an email, Dr. Nachega. If you can give me the course information, I will also post that on Blackboard.
I'll be happy to do so.
So do we have any questions for Dr. Nachega? Come on.
How serious of an epidemic is the HIV epidemic, or how serious of a problem is it viewed in South Africa? Because from, I think, an American perspective, it seems like a massive problem. How seriously is it taken?
So thank for the question, and I think that's a good question. Just let me say that about 4 years ago, more than 4 years ago, I think there was a lack of political leadership to take seriously this epidemic in South Africa, while people were dying and really massively. So the President Mbeki era, which was during the 1980s, where the epidemic was just exploding, failed to take a really strong leadership to try to get people tested, and more importantly, providing people treatment. South Africa is one of the richest country in Africa, so they can afford for South Africans to provide them treatment. It was only until this current leadership under President Zuma that there been really a strong reaction, strong response to try to address this epidemic in South Africa. First of all, by scaling up HIV testing in all provinces, by increasing coverage of treatment, but also by trying to increase campaign for prevention. And then as I told you, this is really, South Africa has the highest number of HIV infected, not only in Africa, but also in the world. 6 million people are HIV infected in South Africa. So I think if we can afford to get everyone tested, and treated as soon as possible, I think it will make a huge difference over time by decreasing the new case of HIV. As you know, HIV impacts the society, the economy, the defense force. So the implication, national level, it's really huge. So again, in summary, we finally making a difference, but that difference was not there initially because of lack of political leadership. Now the current leadership is being really strong, and I'm really happy to say that.
Other questions?
I would like also to add, thanks for PEPFAR. PEPFAR is a U.S. response. So under President Bush, there was substantial resources in terms of funding that was provided to treat most HIV people infected in Africa. And South Africa did benefit from the presidential fund against the HIV, tuberculosis, and malaria under PEPFAR program. And this is a program that all people in Africa, including South Africa, are saying thank you for the United States. Because without PEPFAR, majority of people who cannot afford drug could not get treated. And so today we're seeing a decrease in mortality because of the generosity of the American people.
Do we have any other questions? Would you mind just coming up, please? Thank you. Tall so he can see you.
So for your treatments to prevent the spread of HIV and AIDS, how would that be subsidized by the government? Would it be paid for by taxes? Would the individual be responsible for it, or would it be completely government subsidized?
Thank you. That's a tough question. So the question your colleague is asking, I did mention that for the treatment to have a preventive action, preventive effect, people need to get tested, and as soon as they are tested, they need to be treated, and not, try to wait until some kind of threshold of immune deficiency to get started on treatment. So that means you need to increase the eligibility. You need to increase the number of people who are going to require treatment. So who's going to pay for it? It's still not. We don't yet have an answer on that question. While scientifically we know that's the way to go. So I think the community, both the scientific community, the politician, the economist, everyone have to come up and try to see how one can cover community with the treatment, and where to access, the fund to have everyone covered for treatment. So this is I think we need to be creative here, and I think a partnership between private and public sector will be critical. I know they've been Gates Foundation, has been doing great donation in Botswana, which is just a neighbor country of South Africa. Botswana is a very small country, and where you can cover probably most of their people who get tested and put on treatment right away. So for those small countries where the number of people infected are relatively not as much as in South Africa, you can be able to cover all of them. But the issue also is that you need to sustain treatment over time. So there's always going to be a demand over time. I mentioned PEPFAR. PEPFAR is being able to kick off access to treatment, but in the current financial, crisis, international financial crisis, PEPFAR is in somewhat having challenge to sustain its contribution. So I think PEPFAR is trying to being helped by Global Fund, which is a more at United Nations level, but we're going to require for test and treat and prevention action of the treatment. We're going to need more than PEPFAR, more than Global Fund. So any private donation is going to be welcome. Any involvement of African government themselves for their health of their people going to be critical. But it's not acceptable that some African governments are spending more for military than for the health of their own people. So I think it's going to be a lot of political leadership to try really to meet the demand of test and treat. So thanks for asking this question, which is being currently debated at the World Health Organization and United Nations by the UN-AIDS.
Did we have a question? And then, right, so we can see you.
Hi, I just had a quick question about who's at the forefront of leading the kind of the HIV prevention and treatment. What did you say is the government or more so NGOs and the UN? And is there cooperation between these two different areas to make sure that they have the highest, effective rate that they could possibly have?
So it depends country by country. Let me just start for South Africa. South Africa, as I mentioned, it's the richest country in Africa. So the government is paying for treatment of all HIV-infected persons. So if you are in South Africa, you've been tested positive, the government going to pay the treatment for you. So the treatment is free of charge in South Africa. And currently the guideline, the recommendation are that you are being put on treatment when your CD4, which is the biological marker, which show how far you are advancing the disease. If the CD4 is below 350, it comes from 250, now it's 350, they increase the threshold, so you will be put on treatment, and this is free of charge. So, but other people in Africa are not so lucky. In country like in Congo, Democratic Republic of Congo, the government don't pay for treatment. And if you are not able to access an NGO, so you're going to die. And in some place there is no NGO, like in East Congo, where there is a lot of fighting, so political and so in those settings, basically, only the NGO are on forefront of treating people. But again, regardless where you are in Africa, no one has embarked on testing and treating right away. So this new strategy, it's something that is still experimental. People trying to get more data until they can implement widely it. It's going to cost quite more. So far, people are being treated just as soon as they get lower than 350. But if you have 500 or 600, they tell you to come every 3 months to check your CD4 until your CD4 reach 350. I am currently sitting at WHO guideline. The new WHO guideline going to come up. They're going to push the test and treat. They're going to push the government to try to treat their people right away. It's going to be not easy because there's still people dying in some other country, as I say, because they're not accessing treatment, even they're still below 350. So it's going to be an ethical challenge to try to prioritize it will make more sense. The patient who's likely to die because the CD4 are so low, to get them treatment if the resources are limited. So until you secure enough resources for the people, it's going to be really unacceptable to start and test and treat, even if it scientifically it makes more sense, but it require more resources, and this can be worked out step by step. So the WHO next guideline going to push each country to look at own resources, to mobilize resources, and as soon as everyone that is covered who are in urgent need of treatment get treated first until we embark to people who are still healthy for the benefit of the community. I hope that makes sense. So basically, all countries in Africa are not the same in terms of who is leading. It depends of a variety of circumstances and the wealth of each nation. But again, in other countries, as I say, PEPFAR is sometimes the only person providing treatment. So again, I have to admit, without PEPFAR and the Global Fund, probably majority of patients in Africa will not accessing treatment because governments are not providing them for them.
Dr. Nachega, we have 2 more questions. Is that okay with you?
I'm fine.
Perfect. Keep going.
I was wondering. I know that there's about 10% population in South Africa who's white, and then 90% who are African or other ethnicities. How is the prevalence of HIV related to ethnicity in South Africa? Is it more of a problem in one community than the other?
So the demographics figure you just say are correct. So just to give a background to those who are not familiar with South Africa, so there is about 80% are Black African, about 8.9 are from mixed marriages, and about 9% are white, 2.5% are Indian, and 0.5 are other. So it's a very heterogeneous, very rich culturally society. It just reminds me when I'm in South Africa, like I'm in New York City. But that kind of heterogeneity in terms of ethnic, it brings also some heterogeneity in terms of wealth, and obviously majority of Black African live under poverty. And as I just showed you, poverty is one of the risk factors which tend to get especially young women to be vulnerable to acquire HIV. So then it turned out that majority of HIV infection here are among Black Africans. So that's the reality, which is multifactorial.
Hello. You had mentioned the current treatment that South African government pays for. I just wanted to know what is it costing the South African government per person, whether it's in a year or a month? And is this the HPTN or is it still the older antiretroviral treatment?
So I don't have handy the cost of treatment that government is covering. I can get you those data if you send me an email, and I can get them to you later. As far as the regimen, currently every HIV infected person in South Africa, the regimen is it includes a drug called tenofovir, and then FTC and adherence. That's the first line regimen. It's a combination of 3 drugs, which includes tenofovir, FTC, and adherence. there is a second line which includes what we call a protease-based inhibitor, and with 2 nucleosides. But majority are on the first line. It's a very powerful combination. It's about the same that is being used in the United States currently. So the DHHS and NIH recommend the same regimen for those who start treatment in the US. So in some way, there is now an equity for an HIV-infected person who start treatment. We have to start treatment in South Africa or in the United States. They're going to start the same regimen, which is being proven to be effective through a really rigorous randomized control trial. So the treatment that was used in HPTN includes such treatment regimen I just mentioned here, and is being now increasingly used in Africa. The all previous toxic regimens that are being used in Africa are being now phased out in most African countries. But you can still, in some countries, you can still have D4T, stavudine, which have horrible side effects, which some people are still using in Africa because they're cheap. But hopefully WHO is pushing government to get rid of them and to use the more friendly, less toxic treatment that are being used everywhere now, including the United States. The issue in Africa that you may ask is having generics instead of brand drugs. So there is agreement with a pharmaceutical company for African government to access generic at lower cost. So that will help them to purchase more medicine for the people. So this is happening in South Africa and most of African countries. So where people here are using mostly generic, as compared to United States, patients are using brand medicine.
So we have one last question for you.
Hi, doctor.
Yes.
I'm a South African myself, so I just want to know from you. You mentioned in your recommendations that there needs to be a change in the norms concerning intergenerational relationships. So I want to know from you, how do you think we should go about doing that?
So that's an important question, and I'm glad you're asking it. And I'm glad to see there is a South African in the audience, and hopefully feel free to email me if I say something that is not accurate about South Africa. So the point here, this is an interesting point and very social and cultural issue, which is not specific for South Africa. You have it in Botswana, you have it in some other African country, and as I said, it's related to poverty. But I think there is one way to try to break this that kind of a vicious cycle. It's to try to empower young women. It's try to empower people, to get people, to try to fight against poverty at family level, but empower family, but also empower directly women, getting them to find jobs that they can then get some salary and support themselves, and not relying on some older people who gonna just having them for sex and getting them HIV, getting them infected. And I think I can send later for those who are interested. There is a paper published in the Lancet. These are data from Malawi. Again, Malawi is another African country. This is a study conducted by one of my colleagues at GW, George Washington University, Sarah Bird. She's an assistant professor at GW who just finished a randomized control trial published in the Lancet, showing that in younger women, if you give them monetary incentive, just some small money every week or monthly to try to some pocket money, they're less likely to acquire HIV as compared to a control group in that study. So that is really a demonstration that fighting poverty, try to secure the needs and this not need to be really huge. Just some small incentive to try to fight poverty can change, the life of those young people. And again, that study published in the Lancet is so powerful because it shows really if you empower people, they're less likely to engage themselves in very risky behavior.
Okay, well, helping and thanking Dr. Nachega for his time. Dr. Nachega, thank you so much for Skyping with us, and I will share your information with the students, and once I receive your course information for this summer, I will post it on Blackboard too.
Thank you. Have a nice weekend, everyone.
Thank you.